Good afternoon, everyone. The FDA Office of Women's Health is really pleased to bring this continuing education program to you today. Our mission is to protect, promote, and advance the health of women through regulatory science, outreach, engagement, and educational programming. And we are really excited to collaborate with our colleagues from the Center for Drug Evaluation and Research for today's important and timely discussion on menopausal hormone therapy. So thank you all for joining this webinar today. The title of today's presentation is FDA Menopausal Hormone Therapy Labeling, Historical Context and Recent Changes. And I'm pleased to introduce our two featured speakers. I will start with Dr. Nicholas Hazen. He is an OBGYN physician, gynecologic surgeon, and medical officer in the FDA's Office of New Drugs Department of Urology, Obstetrics, and Gynecology. He received his undergraduate degree in computer science at NYU and worked in the telecommunication industry for nearly a decade before earning his medical degree from George Washington University. He completed medical residency in OBGYN at MedStar Georgetown University, Washington Hospital Center, where he served as administrative chief resident. At MedStar, he served in multiple leadership roles, and in 2024, Dr. Hazen left full-time clinical practice to join the FDA. He still maintains a small GYN practice at Georgetown and continues to serve as a surgical mentor and direct the residency's simulation program. Dr. Hazen has received multiple awards and recognitions, including APGO's Excellence in Teaching Award and Washingtonian Magazine's Top Doctor. He has authored many peer-reviewed articles covering a wide range of subjects in both obstetrics and gynecology. Thank you for being here, Dr. Hazen. Our second speaker is Dr. Aisha Johnson, who is a family and preventive medicine boarded physician, currently serving as the Deputy Director for Safety and the Associate Director for Labeling in the Division of Urology, Obstetrics, and Gynecology in FDA's Office of New Drugs. Prior to this role, Dr. Johnson was a medical officer in the Office of Compliance, Good Clinical Practice Assessment Branch, where she was involved in activities related to clinical site inspections. Dr. Johnson joined the FDA by starting in the Division of Gastroenterology and Inborn Errors Products as a medical officer in 2007. She earned a Bachelor of Science in Chemistry from Howard University and her medical degree from the University of Maryland. She completed a family medicine residency at Florida Hospital Orlando and subsequently completed a preventive medicine residency at Johns Hopkins University. Dr. Johnson also obtained a Master of Business Administration and a Master of Public Health degree from Johns Hopkins. Thank you for being here as well, Dr. Johnson. And so with that, please join me in welcoming both speakers. Dr. Hazen, feel free to kick us off.
Good afternoon, everybody. Thank you, Lorraine. Before I begin, Dr. Johnson and I would like to say thank you to the FDA Office of Women's Health and the Grand Rounds team for supporting today's talk and women's health in general. Also, a big thank you to our division and office leadership for entrusting us to work on such an important project. All right, let's get started. I have no disclosures today, and today's presentation will include FDA reference to FDA-approved products that are being used for non-indicated purposes. There are three goals for my presentation today. First, to delve into the history of the usage and regulation of menopausal hormone medications. Second, to discuss the context of medication use and scientific questions leading up to the design of the Women's Health Initiative trials. And third, to discuss the results and the impact of the early WHI publications, including what we know about changes in use patterns, as well as the regulatory changes. Specifically, we'll review the FDA labeling. I would also like to include the caveat that even in a non-in-depth discussion of this topic, we could fill an entire afternoon. I've compressed this into a concise summary that I hope will provide an accurate and accessible context for those not familiar with this area of medicine or medication history. To do this, some of the transitions may feel like we're jumping from first to fifth gear, but let's dive in. We'll start with the very basics. Menopause is a natural process in a woman's reproductive life. defined as occurring 12 months after a woman's last menstrual period and an average age of 51. The decrease in ovarian estrogen production plays a key role in the associated symptoms. Hot flushes or hot flashes and associated night sweats are referred to as vasomotor symptoms or VMS. Vasomotor symptoms are the most common menopausal symptom, with moderate to severe symptoms affecting 1/3 of women ages 40 to 65. Vasomotor symptoms most often start in the years preceding menopause and continue with an average duration of up to 10 years. Estrogen-containing menopausal hormonal therapy has been shown to be an effective treatment for the relief of vasomotor symptoms, as well as another constellation of menopausal symptoms, genitourinary syndrome of menopause, or GSM, which we'll discuss shortly. Let's talk a little bit more about what we're treating. The goal of treatment in menopausal hormonal therapy is to alleviate symptoms, not necessarily to mimic premenopausal hormone levels. The lack of need for replacement per se is why we generally no longer refer to this class of medications as replacement therapy or HRT. Now, a little bit more about the symptoms that we're treating. Moderate vasomotor symptoms are defined as the sensation of heat with sweating. When those symptoms interfere with activity, they are classified as severe. Genitourinary syndrome of menopause, or GSM, and vulvovaginal atrophy, or VVA, are a related group of symptoms associated with changes to the female genital and urinary tract caused by a decrease in estrogen. We now commonly use the term GSM because it includes a broader array of symptoms. However, because of nomenclature norms at the time of approval and the specific indications, the current FDA-approved drugs carry the indication to treat vulvovaginal atrophy or an individual symptom of VVA. The symptoms associated with vulvovaginal atrophy are vaginal dryness, vaginal and/or vulvar irritation or itching, pain with urination, vaginal pain associated with sexual activity, and vaginal bleeding associated with sexual activity. Osteoporosis is also often associated with states of decreased estrogen and is characterized by low bone mass and deterioration of bone tissue microarchitecture. Estrogens are the primary component of MHT that are responsible for symptom relief. Natural estrogen comes in three main types: estradiol, which is primarily produced by the ovaries. This is natural estrogen's most potent form and is the body's primary estrogen source during reproductive years. Next, we have estrone, which is the less potent form made in the body by body fat and the liver. And lastly, estriol, which is primarily produced by the placenta during pregnancy. In addition, there are multiple synthetic estrogens available. The FDA has approved products with a variety of routes of administration, including oral, transdermal, topical, and vaginal formulations. It is important to know that exposure to estrogens alone in a woman with a uterus can lead to uterine cancer. Progestogens or progestins, when taken with estrogen, decrease that risk of uterine cancer. We also have SERMs, or selective estrogen receptor modulators. These act as an estrogen on some organs and as an anti-estrogen on other organs, and they can be used alone to treat symptoms or for endometrial protection like a progestogen. Okay, those are the very basics of the meds and what they do. Now let's talk a little bit about what we knew and how these meds were used before the pivotal trial, the WHI, which we'll focus on later in the talk. Medications to treat menopause are not new. In the 1890s, powdered cow's ovaries were used to make a product called Ovarin, and in the 1930s, the urine of pregnant women was used for its hormonal content. In 1941, the FDA approved its first product indicated for the treatment of menopausal symptoms. Use continued to grow throughout the 20th century, and the 15 years or so between 1960 and the mid-1970s alone, use tripled. There was a sharp but temporary decline in 1975, following reports of increased endometrial cancer, but this pause was short-lived as studies soon demonstrated that the addition of progestogen prevented that risk. By the early 2000s, MHT was used by an estimated 15 million American women, which was approximately 1/3 of the menopausal population. Let's dig a little bit deeper into the endometrial cancer risk reported in the mid-1970s. In 1975, two retrospective studies linked endometrial cancer to estrogen use without a progestogen. Following those studies, in 1976, the FDA required a prominent warning of the risk of endometrial cancer on estrogen menopausal hormone therapy products. This warning, pictured at the bottom of the slide, this warning is pictured on the bottom of the slide. Of note, This box was in place before the official FDA box warning was even created. In the early 1980s, it was demonstrated that adding a progestogen significantly reduced the risk of endometrial hyperplasia. And in the mid-1990s, the PEPI trial confirmed that combined estrogen plus a progestogen had endometrial hyperplasia rates similar to non-hormonal placebo controls, which were around 1%, even though endometrial hyperplasia is a precursor to endometrial cancer. Let's talk a little bit about the history of use of the box warning. The box warning, often unofficially called a black box warning, saw its regulatory inception in 1979 and has three primary justifications for use. One, the risk is so serious in proportion to the benefit that it is essential to be considered before using the drug. Two, there is a serious reaction that can be prevented or reduced by appropriate use of the drug. A good example of this is the need to add a progestogen to estrogen menopausal hormone therapy to prevent uterine cancer. And lastly, three, the drug was approved with restrictions because the FDA concluded that the drug can only be used safely if distribution or use is restricted. Okay, enough on regulation for now. Let's get back to the 1980s and 1990s. Leading up to WHI, there was mounting observational evidence of menopausal hormone therapy use imparting benefit for its users beyond just the menopausal symptoms. These data primarily showed a decrease in heart disease, with some studies suggesting that MHT use could cut cardiac risk by half. The results were convincing enough for the American College of Physicians to create guidelines suggesting CHT protection in at-risk groups with hormone therapy use. However, these data were all from observational studies, which can demonstrate correlation and association, but cannot show true cause and effect. It's also important to note that not all the studies at the time agreed on those observed benefits. This brings us to the HERS trial. This was a randomized controlled trial in women who already had heart disease, and it found no overall reduction in the risk. Taken together, all of these results left some big unanswered questions. I'm going to take a pause here on heart disease and talk for a minute about breast cancer. Throughout all of this time, there was mounting observational evidence that breast cancer was higher in women who were taking hormones, and as stated earlier, observational studies alone cannot establish causation. But these data added to the list of unknowns for both benefits and risks surrounding one of the most used medication classes at the time. These questions were what the WHI was designed to answer. On to the study. The primary goals of the WHI were to answer whether there was cardiovascular benefit for postmenopausal women who were taking MHT, and whether taking that MHT increased their risk of breast cancer. It was the largest menopausal hormone randomized trial to date and enrolled more than 27,000 women. There were two parallel hormone trials, conjugated estrogen with medroxyprogesterone versus a placebo in women who had a uterus, and conjugated estrogen alone versus a placebo for women who had a hysterectomy. Women with vasomotor symptoms were allowed to enroll in the trial, and a portion of the study participants did report vasomotor symptoms, but the study was not designed to evaluate the impact of medications on those symptoms or look at the population specifically with those symptoms. The objective of these studies was to understand disease prevention. Of note, recruitment was open to women ages 50 to 79, and the average age of the enrolled participant was 63. This meant that the average WHI participant was considerably older than the average woman initiating menopausal hormone therapy for vasomotor symptoms. Both of the WHI hormone trials were stopped early. In 2002, the combined estrogen and progestin trial was stopped when an interval review found that the demonstrated breast cancer risk had met a pre-specified safety threshold. At the same time, the medication use did not demonstrate cardiovascular protection, and given the evidence of risk, without evidence of significant benefit, the trial was halted. The trial overall demonstrated an increased risk of breast cancer, heart disease, stroke, deep vein thrombosis, and pulmonary embolism. However, it also showed protection against both hip fracture and colorectal cancer. On a nerdy but important statistical side note, a trial as large as the WHI is able to detect with a good degree of confidence even rare outcomes. For example, the breast cancer results showed cancer to be 26% more likely in the treatment group. However, in this trial population, this translated into an absolute risk increase of about one additional case in 1,000 women per year. 2 years later, the estrogen alone trial was stopped early as well, when the results demonstrated that there was an increased risk of stroke without sufficient balancing benefit. The Women's Health Initiative Memory Study, or WIMS, was an ancillary study that looked at a subset of WHI patients to evaluate the effect of menopausal hormone therapy on the risk of probable dementia, cognitive impairment, and global cognition over time. This subset was older than the general WHI cohort and started enrolling at age 65. The results showed an increased risk of probable dementia in the estrogen and progestogen group and suggested a risk in the estrogen group alone. In the estrogen alone group. So what does all of this mean? Well, the impact of the 2002 halt was immediate. A press release was timed with the publication of the paper announcing the results. Decline in use following the publication and announcement was rapid. Within 3 months, there was an 18% decrease, and within a year, the decrease was more than 30%. In 2003, the FDA instituted class-wide labeling changes that included a boxed warning. The new warnings were applied to all the products in the MHT class and included risks of pulmonary embolism, deep vein thrombosis, stroke, myocardial infarction or heart attack, invasive breast cancer, and probable dementia. The right half of this slide is an example of such an MHT box warning. The use trend continued downward after the labeling changes and the publication of the 2004 estrogen alone WHI results. Recently, some studies have shown that use has dropped more than 70% from peak levels to less than 5% now. So what's happened since 2003? The FDA has continued to evaluate and listen to our community. In 2015 and 2018, we held a workshop and responded to a citizen's petition regarding the labeling of vaginal products for vulvovaginal atrophy. And in 2025, following a panel presentation, we opened a public docket on the topic that received over 2,900 comments. Since the post-WHI label changes, many concerns about the labels and their impacts have been raised. Some of the most common concerns are listed on the slide here, but tend to focus on whether there was a need for the box warning for vaginal products designed just for vulvovaginal atrophy symptoms, the negative impact that the box warning has had on user sentiment, even when used for appropriate indications, the applicability of the WHI results to the population who are most likely to use these medications, and lastly, the choice of how these data were presented. All right, thank you, everybody. This concludes my portion of the talk. I hope that I've helped you understand the complexity of MHT history, the objectives and the results of the WHI trials, and the underpinnings that led us to the recent changes to the class labeling, which you'll hear about next from Dr. Johnson. Hang tight for a second, here are my references. And on that note, I'll hand the presentation over to Dr. Aisha Johnson. Thank you, everybody, for your time, continued attention to this incredibly important subject. Thank you.
Thank you, Dr. Hazen, for that discussion of menopause and for leading us through the history of the Women's Health Initiative and the menopausal hormone therapy labeling. I have no financial disclosures. And during this presentation, we will briefly discuss the content and purpose of the FDA-approved prescribing information. The term prescribing information is often used interchangeably with the term labeling. As a note of clarity, while labeling is the correct regulatory term, for the purpose of today's discussion, we'll use the term label as it is likely to be more widely understood. As we continue the presentation, we'll discuss the location of risk information in the PI, and then we will go to each of the 8 key recent MHT label changes. For each change, we'll discuss the previous label, the rationale for the change, and the new label. Slides that describe the new label will be highlighted using blue font. The prescribing information contains a summary of the essential information for safe and effective use of a drug and represents the FDA's findings on these topics. It's important to point out that the prescribing information is written for the healthcare provider and not the patient. Patient labeling will not be discussed during this presentation. The primary sections of the label that contain information on adverse reactions are the box warning section, as discussed by Dr. Hazen, which provides a concise summary of information that is critical for a prescriber to consider. The contraindication section describes a clinical situation when the risk clearly outweighs any possible benefit. The warnings and precautions section, which briefly describes a discrete set of adverse reactions or other risks that are serious and have implications for prescribing decisions, and the adverse reactions section. Now that we've discussed the primary risk sections of the label, we'll move on to defining the MHT drug classes and the abbreviations that will be used for the remainder of our discussion. First, we have systemic estrogen plus progestogen, which will be denoted EP. Next, systemic estrogen alone, referred to as E alone. Topical vaginal estrogen alone, indicated only for treatment of vulvovaginal atrophy, commonly referred to as low-dose vaginal estrogen, or E alone topical, and progestogen alone, P alone. With the background on the relevant sections of the label, the abbreviations used for the MHT drug classes, will now turn to the MHT label changes. As discussed previously, for each topic, we'll begin with a brief discussion of how the topic is presented in the previous MHT labels, followed by the rationale for the MHT change, and end with a discussion of how the topic is presented in the new label. Let's begin. Safety information specific to each MHT category. Previously, 3 of the 4 classes contain the same risk information: estrogen plus progestogen systemic, estrogen alone, and vaginal topical estrogen products all contain the same risk information. The progestogen alone labels also contained estrogen plus progestogen risk information. In the new labels, risk information will only be included specific to the relevant MHT drug class. The rationale for this change is that inclusion of information in a label not relevant to the drug that is the subject of the label could detract from communication of important risks. A second part of the rationale for separating MHT risk information into 4 separate categories is the important difference in drug exposure between systemic and local estrogen products, with topical products generally having lower systemic exposure. In the new MHT labels, safety information specific to the relevant drug class will be presented only. In addition, separating risk information by MHT drug class allows the vaginal estrogen alone labels to reflect the differing risk profile of these drugs given their lower systemic exposures. And finally, for the estrogen plus progestogen class, risk information will remain in the label. This decision was made because progestogen alone is often co-prescribed with estrogen alone systemic drugs. Next, we'll discuss the topic of inclusion of age of use considerations in MHT labels. In previous MHT labels, there was no statement on the recommended age to initiate MHT treatment. The rationale for considering the inclusion of age of use recommendations in the labels centers around what is known about the population most likely to initiate MHT for VMS. As Dr. Hazen discussed, the average age of menopause in the U.S. is 51 years of age. The average age of vasomotor symptom treatment initiation is 45 to 55 years of age, while the average age of WHI participants was 63 years of age. The difference between the average age of MHT initiators and Women's Health Initiative study participants is the basis for several changes that we will discuss as the presentation continues. In 2013, Manson et al. Published WHI long-term safety follow-up data by age strata. The 50 to 59-year-old cohort includes the group most likely to initiate MHT for VMS, and therefore it is important to understand the risks associated with MHT use in this key age cohort. The conclusion of the Madsen article was that younger women and those within 10 years of menopause onset had lower overall risk and smaller absolute risk of most of the adverse outcomes reported, including coronary heart disease, venous thromboembolism, and invasive breast cancer, compared to the overall WHI trial population. Based on this information, the new label will add safety information from the WHI cohort of women 50 to 59 years old. The risk information on the overall WHI cohort of women 50 to 79 years old will remain in the new label. In addition, the new label will include a statement that the timing of initiation can affect the overall benefit risk profile and advise providers to consider initiating MHT in women less than 60 years old or less than 10 years since menopause onset. Our next topic is the risk of probable dementia. On the screen, you'll see the text from the previous estrogen plus progestin label. The key statements from the box warning are that estrogen plus progestogen should not be used for prevention of dementia, and the WHI memory study, or WHIMS, reported an increased risk of probable dementia in women 65 years of age or older. The previous estrogen alone label is nearly identical to the estrogen plus progestogen label, with a similar stated risk for women 65 years of age and older. The rationale for updating the MHT label regarding the risk of probable dementia is based on looking at the risks in a younger cohort of patients. As has been mentioned, the 50 to 59-year-old age cohort is most likely to initiate MHT for VMS. In the WHI Memory Study of Younger Women, or WMSY, evaluation of a cohort of women 50 to 55-year-olds, and the KEEPS-COG study of 45 to 55-year-olds showed no increase in risk of cognitive decline associated with MHT use in patients in these younger cohorts, specifically for estrogen plus progestogen and estrogen alone. The new label removes the risk of probable dementia from the boxed warning and warnings and precautions sections in the estrogen plus progestogen and estrogen alone labels. The new label also keeps the WHIMS data regarding the increased risk of probable dementia in women 65 years of age and older. This information will remain in the geriatric use subsection of the use in specific population section, and also will remain in the clinical studies section of these labels. Our next topic is the risk of invasive breast cancer. In previous estrogen plus progestogen labels, the box warning includes an increased risk of invasive breast cancer. Our rationale for updating the estrogen plus progestogen label regarding this risk is also rooted in the consideration of the younger cohort of patients. In the 50 to 59-year-old WHI cohort, seen here in white, there was a smaller risk difference than in the overall WHI cohort. The smaller the risk difference, the lower the risk. Next, we'll look at the risk of invasive breast cancer associated with the use of estrogen alone. Of note, estrogen alone MHT labels did not previously include a box warning, and we can look at these data and see the reason. In both the younger, in white, and overall, in the darker text WHI populations, there was no excess risk of breast cancer seen. It's important to note that from a regulatory perspective, we do not consider these data sufficient to constitute substantial evidence of efficacy for the use of estrogen alone for the prevention of breast cancer, especially considering the data on the effect of estrogen alone from observational studies on breast cancer. Let's look at these observational studies. In 2019, The Lancet published a meta-analysis that showed an increase in the incidence of breast cancer associated with estrogen plus progestogen and estrogen alone. In the new label, the risk of invasive breast cancer is removed from the box warning of estrogen plus progestogen products based on the lower risk of invasive breast cancer in the younger cohort of the WHI trial, combined with the availability of screening tools and the established benefit of MHT for VMS. Breast cancer risk information will remain in the warnings and precautions sections of the estrogen plus progestogen label and the estrogen alone label based on the results of the meta-analysis which showed an increased risk of breast cancer incidence. Our next topic is risk of cardiovascular disease. In the previous estrogen plus progestogen label, there was a box warning regarding the increased risk of DVT, pulmonary embolism, stroke, and myocardial infarction. As was done for previous risks, if we look at the risk difference by age cohort, we see that while there was an increased risk of these events, the risk difference is smaller in the younger cohort for all events than the overall WHI group, denoting a lower risk in the younger cohort. The rationale for changes to the estrogen plus progestogen label is based on the established benefit for the treatment of VMS and the lower risk of these events seen in a younger cohort compared with the overall WHI population. Next, we'll look at the previous estrogen alone label. In the previous estrogen alone label, there was a box warning regarding the risk of stroke and DVT. As was done for previous risk, we'll look at the risk difference by age cohort. We see similar differential risks for the younger cohort of women for estrogen alone. The risk difference here is the same in both groups for pulmonary embolism. The risk difference for MI in both age cohorts is noted to be negative. However, the evidence alone is not considered adequate for substantial evidence for the purpose of indicating estrogen alone to prevent coronary heart disease. The rationale for the estrogen alone label change is the revised benefit risk assessment in light of established benefit for VMS and the differential risks based on age discussed in the previous slide. Now we'll look at coronary heart disease. In the estrogen plus progestogen substudy for coronary heart disease defined as non-fatal MI, silent MI, or CHD death, there was an increased risk of CHD events in the overall WHI cohort and the younger cohort of women 50 to 59 years of age. The risk difference seen was relatively small and nearly the same for both, and the risk difference was nearly the same for both age cohorts. If we look at the estrogen alone group, for coronary heart disease, there was no excess risk of coronary heart disease in both the younger cohort and the overall study population. As was mentioned, the evidence for estrogen alone is not considered adequate for indicating estrogen alone to prevent coronary heart disease. The rationale for changes to the estrogen plus progestogen and estrogen alone labels regarding the risk for coronary heart disease is based on the established benefit for the treatment of VMS. For estrogen plus progestogen, there is a relatively low excess risk of coronary heart disease in both the younger and overall WHI cohorts. And for estrogen alone, there was no excess risk in both the younger and overall WHI cohorts. In the new label, the risk of VTE and ATE, that is DVT, PE, stroke, and MI, is removed from the estrogen plus progestogen label, and the risk of DVT and stroke is removed from the estrogen alone labels. The risk of DVT, PE, stroke, and MI remains in the warnings and precautions section of the estrogen plus progestogen and estrogen alone labels, with the exception of MI, which is not included in the estrogen alone label. Risk of CHD is removed from the box warning for estrogen plus progestogen and the estrogen alone labels. The new label keeps the risk of coronary heart disease in the warnings and precautions of the estrogen plus progestogen labels, given the low attributable risk seen. The new label removes coronary heart disease risk from the estrogen alone label because there was no excess risk seen. Now we'll turn to the risk of endometrial cancer. Previous estrogen plus progestogen and estrogen alone labels contain a warning regarding the increased risk of endometrial cancer in a woman with a uterus who uses unopposed estrogen. The rationale for the label change is rooted in the concept of limiting risk information to the relevant MHT category. Given that the estrogen plus progestogen products by their very nature contain progestogen, and the risk of endometrial cancer can be mitigated by the addition of a progestogen, this risk was removed from estrogen plus progestin labels. In the new label, there will be no change for the estrogen alone systemic products. The risk will remain in a box warning for these products. The risk will remain in the box warning and warning and precaution sections. The risk will be removed from the vaginal estrogen alone topical labels given the lower systemic exposure, but the risk will remain in warnings and precautions of these labels. And the risk of endometrial cancer will be removed from the estrogen plus progestogen labels and the progestogen alone labels. Our next topic is lowest dose, shortest duration recommendation. Previous labels contained a recommendation to use estrogen for the lowest dose and shortest duration consistent with treatment goals. The recommendation was included in the box warning and dosage and administration sections. The rationale for changing this recommendation is rooted in the inclusion of more specific guidance based on literature recommending that healthcare professionals consider initiating treatment in women less than 60 years old or less than 10 years since menopause onset. The new label removes the recommendation to use MHT at the lowest dose for the shortest duration and instead includes more specific guidance regarding timing of initiation of menopausal hormone therapy. And our last topic is topical vaginal estrogen. The previous label, as I mentioned, contained the same risk information as the systemic estrogen-containing products. The rationale for changing the topical vaginal estrogen alone labels is rooted in the generally lower systemic exposure of these products, leading to uncertainty regarding the relevance of these systemic risks to these vaginal topical products. The new label for topical vaginal estrogen removes the box warning that includes the risks of systemic estrogen plus progestogen and estrogen alone. These risks were discussed previously in this presentation. In its place is a summary of estrogen alone risks and warnings and precautions. This summary of risk is based on systemic estrogen, interpreted in light of lower exposure, and prioritized by relevance to the vaginal formulation. We've discussed quite a few changes, but each of the changes to MHT labels seeks to provide nuanced risk information relevant to the target population, tailored to the specific MHT category to better inform the healthcare provider's recommendations to individual patients. The changes are based on additional WHI analyses, including subgroup analyses, meta-analyses, and the results of long-term WHI follow-up. Thank you for your time and attention, and I'll turn it back over to our Office of Women's Health hosts.
Thank you so much, Dr. Hazen and Dr. Johnson. Those presentations were excellent, such a great delivery. We are so happy to be joined by Dr. Christina Chang and Dr. Christine Nguyen from the Center for Drug Evaluation and Research to address questions. So let's get started. I see the first question here. It's a really good one. So the question here is, what does the agency say to women who may still be hesitant to use MHT based on more than 20 years of warning about increased risks and serious adverse events?
I'll take that question. So good afternoon. Thank you for joining us. I think that question applies to many women who are considering using the menopause hormone therapy to address their symptomatic relief. I think as in any other, as in with any treatment, there are benefits and there are risks, and both are important to the equation. It's not just one or the other. We really have worked hard to make sure that we present the risk information as clearly as possible and as balanced as possible. We certainly recognize and appreciate that the menopausal symptoms can severely impact the quality of life and that these treatments are effective. In our revised label, we actually put down numbers to help prescribers counsel their patients. We put in relative risk and we put in the risk difference. For example, the risk of 5 additional cases of blood clots per 10,000 women per year. That's very helpful to put that risk in context. So we advise women to talk to their prescribers, really understand the magnitude of these risks as it applies to them personally, and also their need for symptom relief. Thank you.
So much for that really thorough response. So our next question I see here for you, Dr. Chang, do companies have to comply with FDA's request?
Thank you, Laureen. No, the companies are not required by law to comply with our requests, but I'm happy to report that many companies have responded favorably to our requests. And as the website indicated, that back in February, we approved revised labeling for 6 products out of the total of 29. I know the website indicated 30 products, but 1 product has since been withdrawn. So we're working on, we have 29 products to which we requested labeling changes. And we have received responses from many companies, and we're working on revising and reviewing their responses and finalizing the labeling. Thank you.
Thank you. Thank you so much.
Yeah, may I add just to our
of course.
audience that if you like to see what each of the hormone category new drug label looks like, please go to our website, because when we approved our first batch back in February, we've approved at least 1 drug label in each of the 4 categories. So if you want to take a look at what the new label looks like, we highly encourage you to go to our website for that information.
Thank you, Dr. Wynn, for that addition and clarification.
Yeah. So I'm looking at other questions here. We have one more, I think, probably for you again, Dr. Chang. So the question here is, were these therapies always safe and mislabeled as unsafe? It's a good question.
Yeah, thank you, Lorraine. That is a great question. So we always strive to provide the public with labeling that's the most up-to-date, current, and presents the accurate and balanced information about the benefits and risks of the drugs. So the question goes to whether the WHI studies were faulty. And so it's important to stress that the WHI studies were not flawed in their design and their conduct, because they were primarily aimed to look at the impact of hormone therapy on cardiovascular disease and other chronic medical conditions in postmenopausal women across all ages. But as the presentations showed, that the average participants, the age for the average participants, for the participants in WHI studies, was 63 years old, although the average age for women who are starting or considering menopausal hormone therapies to treat their menopausal symptoms were likely between 45 and 55 years old. So there is a mismatch between the average age of postmenopausal women who are looking at these therapies and the postmenopausal women evaluated, enrolled into the WHI trials for disease prevention. So the effort that we implemented really was to make sure that our labeling provides the most current information that's accurate and balanced to help women and their providers make informed decisions. Back to you. Thank you, Lorraine.
Yeah. Through, I think that is all the questions we have. If you're comfortable with wrapping up our Q&A, um, and also in the interest of time. So I think we'll wrap up our Q&A, and I just want to thank our audience for joining us today, and a big, big thank you to our speakers and all our collaborators, Dr. Nguyen, Dr. Chang, and of course our FDA Grand Rounds folks. So I will pass it off back to Rakesh.
Actually, Lorraine, if I may,
Yeah,
I just wanted to add one final comment. This was an important important piece of work from the division, from the office, not only in OND, but I definitely want to acknowledge our colleagues in the Office of Surveillance and Epidemiology, our colleagues in the Division of Epidemiology, assisted with review of the literature. So sincere thank you to them too.
thank you for that addition. Thank you both.